know the layers of the blood vessels: tunica intima, tunica media, and tunica adventitia. What you are seeing here, you are seeing some bluish material which is deposited in the blood vessels in the media, tunica media. So in the tunica media, there is deposition of some bluish material, which is that bluish material in the tunica media. If I say this is the blood vessel section of the arteries from a 70-year-old man, yes, 70-year-old man, elderly man, with basophilic material deposited in the tunica media. If I say this is calcium, yes, this is tunica media calcium deposition. This is monkey bird's medial sclerosis. The answer is monkey bird's medial sclerosis. Monkey bird's medial sclerosis is nothing but the deposition of calcium salts in the tunica media of the blood vessels. So it is a type of age-related degenerative change which can occur in the blood vessel. So this is an age-related degenerative change. And the points which you have to know in relation to this finding is, here the calcium deposits, what is the type? This is an example of dystrophic calcification. So dystrophic calcification is nothing but it is the deposition of calcium in dead and degenerated tissues. So D for D, you can remember dystrophic calcification, dead and degenerated tissues. The calcium levels may be normal, okay, but in contrast, the in metastatic calcification, okay, the calcium levels are abnormal, and these abnormal calcium levels, high calcium levels, may get deposited in a living tissue, that is metastatic calcification. So dystrophic calcification in dead and degenerated tissues, here in old age, because of the age-related change, there is deposition of this calcific material, okay, in the tunica media of the blood vessel. So such material deposited in the tunica media as a dystrophic calcification is monkey bird's medial sclerosis. Third question, not a predisposing factor for atherosclerotic plaque formation, which is not a predisposing factor for atherosclerotic plaque formation. The options are ApoE, alpha-2 macroglobulin, oxidized LDL, increased homocysteine. ApoE, alpha-2 macroglobulin, oxidized LDL, increased homocysteine. So we can classify the risk factor for atherosclerotic into, like we know that standard that modifiable risk factors and non-modifiable risk factors. Under non-modifiable risk factors, you have the genetics, age, gender, male gender, and some genetic risk factors. These are all the non-modifiable. And you have the modifiable risk factors like your hypercholesterolemia, hypertension, smoking, diabetes, obesity, type A personality. These are some of the modifiable risk factors. In addition to that, now the recent concepts, that is the emerging concepts which are put forward this atherosclerotic plaque, okay, or like they are saying that even elevated plasminogen activator inhibitor, okay, PAI, elevated plasminogen activator inhibitor, and thrombin. These are all the risk factors. And C-reactive proteins. C-reactive proteins are elevated in atherosclerosis, and this is the most sensitive marker of inflammation that can correlate with the ischemic heart disease. So remember, in atherosclerosis, the C-reactive protein, if you estimate the C-reactive proteins and if you found to be it is very high, so it is a very, very sensitive indication, that very, very sensitive marker that the ongoing inflammation is there. So the patient is a risk factor, high risk factor for this ischemic heart disease. And the recent factors, recent Robins are said that herpes virus, cytomegalovirus, chlamydia pneumonia, all these infections has predisposes the individual to the development of atherosclerosis. In addition to this, ApoE, okay, and oxidized LDL, increased homocysteine are also a predisposing factor, but alpha-2 macroglobulin is not a risk factor. You know ApoE, okay, apoprotein, apolipoprotein, and oxidized LDL, the LDL, that low density lipoproteins, which is oxidized, which is phagocytosed by the macrophages, okay, which are called as foam cells. All these are all happening in an atherosclerotic plaque. And increased homocysteine, the metabolic disorder hyperhomocysteinemia, is a predisposing factor for atherosclerotic. What is not here is alpha to macroglobulin. So the answer here is alpha to macroglobulin. The other question, the fourth question, all of the changes are seen in an atherosclerotic block at the time of rupture, except, so you have the options, four options, that is thin fibrous cap, multiple foam cells, smooth muscle cell hypertrophy, cell debris. Thin fibrous cap, multiple foam cells, smooth muscle cell hypertrophy, and cell debris. Okay, so for answering these questions, we have to understand the pathogenesis of atherosclerotic plaque formation. So if you see the pathogenesis, we have seen so many risk factors. That is an endothelial injury, which can be caused by an hyperlipidemia, smoking, homocysteine. There can be viruses or biological agents. So all these things will cause a damage to the intact endothelium. Okay. So when the endothelium is intact, nothing happens. The blood vessel is protected from the thrombogenic factors. Okay. So, but when the endothelium is getting damaged, okay, when there is a damage to the endothelium, especially because of these risk factors, okay, so what happens, that concept, the theory put forward is the endothelial injury hypothesis. So when there is a response to the hypothesis, what happens, the blood macrophage, the blood monocyte will gain its entry into the tunica media. Okay, the blood monocyte will gain entry into the tunica media, and this monocyte will be trying to engulf that lipid particles. The monocyte will try to engulf the lipid particles. So lipid particles are highlighted as yellow. So what happens, this lipid part, the monocyte will keep on engulfing the liquid particle, that is at oxidized LDL, which I told. Okay, so that oxidized LDL. So what happens, so the smooth muscles from the tunica media, so you know that there are smooth muscles in the tunica media. So those smooth muscles will start to proliferate in the, will start to migrate. Okay, the smooth muscles will start to migrate into the tunica intima. So smooth muscles also starting migrating. So after this, you get a fully formed, well formed atheroma, which composed of this central necrotic core, that is that yellowish material, that is the lipid material, that lipid material, and your foam cells, the macrophages, which have engulfed, the macrophages which have engulfed the lipid particles, are now called as foam cells. Okay, so foam cells are nothing but these are all the modified macrophages. You can see here these foam cells. Okay, so these foam cells with a lot of modified this LDL, that is oxidized LDL, and that necrotic debris, that yellowish material is the atheromatous material. Okay, those atheromatous material, and which cholesterol crystals, necrosis, all this, the central core will be very much soft and will be very much soft. So you will be getting these smooth muscles will be covering these central core like a cap. Okay, this will be covering like a cap. Okay, this is called as a fibrous cap. Okay, now what happens, the endothelial injury happened, no, initially it slowly tries to heal off, and it will be just overlying that fibrous cap. Okay, so now our question is asking, all the changes are seen in an atherosclerotic plaque at the time of rupture, except, okay, so what you can see, thin fibrous cap, multiple foam cells, cell debris also you can see, but you cannot see a smooth muscle cell hypertrophy. Yes, if that thin fibrous cap, if there is this fibrous cap is very much thin, it is more prone for that injury. Okay, if this a thick fibrous cap, injury may not damage that area, that fibrous cap. If the fibrous cap is very thin, any force can easily damage it. Yes, then multiple foam cells, obviously you know that these are all the foam cells. So in that atheromatous plaque, when it is a well-formed plaque, you get multiple foam cells. Okay, so multiple foam cells, it is a well-formed matured thing. Okay, and what is not seen here is the smooth muscle cell hypertrophy, because it is not a hypertrophy which is happening here. It is just a migration of the smooth muscles. So the smooth muscles just start migrating from the tunica media into the tunica intima. So it is just a migration of the smooth muscles into the tunica intima instead of that hypertrophy. It is not a hypertrophy, it is a migration. And obviously you know that Any arteriomatous block will have that cell debris. I told you in the central you will be having a central necrotic core, and the central necrotic core which will be very soft and the yielding, no? So you will be consisting of the cell debris. So the answer here is smooth muscle cell hypertrophy. So this is how an atherosclerotic plaque appears, which will be like an yellowish elevated structure. Okay. So the major sites of atherosclerosis, it is essential to know abdominal aorta and iliac arteries, coronary arteries, thoracic aorta, internal carotid arteries, and cerebral artery. So these are all the major sites of atherosclerosis, major sites of atherosclerosis. The next question which we will see is, a 70-year-old man has abdominal pain with mass in the abdomen. So it is an elderly man with an abdominal pain and a mass in the abdomen. So he presents with a mass in the abdomen. So the angiography reveals aneurysm of the aorta. So the most likely cause is trauma, atherosclerosis, syphilis, congenital. So they are told trauma, atherosclerosis, syphilis, and congenital. Before solving these questions, we have to know that it is the mainly when there is an atherosclerotic aneurysm, the most common site of atherosclerotic aneurysm in the body is the abdominal aorta. Okay, so when you get an aneurysm, when you get a patient with aneurysm, especially in the abdominal aorta, it is mainly because of the atherosclerotic etiology. So that in the abdominal aorta itself, the commonest site is that below the renal artery and above the bifurcation. So that is the, like before bifurcation and below the renal artery, that area will be going in for aneurysm. Okay. Then commonest coronary artery involved in the atherosclerosis is the left anterior descending artery. So you get coronary arteries also, we saw, no, that is one of the artery involved in the aneurysm. So that most common artery involved in the atherosclerosis is the left anterior descending artery. And the most common peripheral vessel showing aneurysm. Peripheral vessels also can go in for aneurysm, and the most common peripheral vessel is the popliteal artery. Popliteal artery. And also just remember the fact, uh, in syphilis, usually you will be getting the thoracic aortic aneurysm. So syphilitic aneurysm usually affects the thoracic aneurysm. So a trauma, there need not be any aneurysm. It will be usually the rupture, and the congenital usually will not be there in the abdomen. Okay, so the answer options on analyzing all these options, the answer for this question will be atherosclerotic aneurysm. So register in your mind, atherosclerotic aneurysm will be common in the abdomen. Okay, common in the abdomen, and the site is below the renal artery and above the bifurcation of the aorta. Okay, let us see this question. In DBACI classification, dissection of ascending and descending aorta is classified under type 1, type 2, type 3, type 4. So for solving these questions, we have to first know like what is dissecting aneurysm. So then only we know that how it is classified. Okay, so dissecting aneurysm is nothing but in certain conditions, say for example, for the normal blood flow to occur, the vessel wall also should be very strength. Okay, that collagen fibers, the connective tissue that holds the blood column in the blood vessel should be very much tight, will be very much strong. And also the blood flow should be, or the uniform smooth flow, it should be a smooth uniform. So when there is an imbalance between these things, that is either the vessel wall is weak or the blood flow is very fast. Okay, the blood flow can be very fast with a very turbulent blood flow, or the vessel wall is very weak. So in these conditions, okay, what can be the condition which cause a weak blood wall, weak blood vessel wall? It can be a connective tissue disorder, or it can be a Marfan syndrome. So what happens this Marfan syndrome? The collagen fibers will become very weak. Marfan syndrome is actually a deficiency, actually a mutation in the protein fibrillin, no? Fibrillin gene, no? So that collagen fibers, that vessel walls and all will be very weak. So the weak vessels cannot hold that vessel blood column in the central very strongly. And also say for example in hypertension. So what happens in the hypertension? The blood flow will be very turbulent. In hypertension, the blood flow will be very turbulent. The blood will be hitting at a very turbulent rate. Okay. So what happens in these conditions, in these hyperdynamic conditions? So what happens? The blood may hit a weak wall. Okay. And it may pierce the tunica intima. It may pierce the tunica intima and it may even tear the tunica media. Okay. It may be tearing the tunica media and it will be dissecting. That means it will be clearing the tunica media and in the blood flow like a dissecting, like a scissor, it will be dissecting the tunica media and it will be entering, forming a separate column of blood in the tunica media. It will be forming as a separate column of blood in the tunica media. Okay, so you will be getting two columns of blood flowing in the blood vessel. So this is sometimes called as double-barreled aorta. So this is sometimes called as a double-barreled aorta. So this is also an MCQ. So dissecting aneurysm, you will be getting a double-barreled aorta. Okay, so what happens here? Either the vessel wall is weak or the blood flow is hampered. So you have in conditions like Marfan syndrome, Ehlers-Danlos syndrome, hypertension, pregnancy, especially in the third trimester, okay, because of the hormones may weak the walls of the blood vessel. So in all these conditions, it's a predisposing factor for the dissecting aneurysm. Now coming to the DVACI classifications. Okay, you have two types of classification for this dissecting aneurysm: DVACI classification and the Stanford classification. So DVACI classification is mainly the type 1, 2 and 3, and Stanford classification you have type A and type B. So listen carefully. DVACI classification, it involves both the ascending aorta as well as the descending aorta. DVACI classification involves both the ascending aorta and the descending aorta. DVACI2 classification, it affects, if the aneurysm affects only the ascending aorta, only the ascending aorta is involved. But DVACI3 is only the dissecting and only the descending aorta is involved. So you have two types of classification, DVACI and Stanford. First, we are seeing the DVACI classification. So in the DVACI classification 1, both the ascending and descending aorta is involved. And in DVACI 2, you have only the ascending aorta is involved. And DVACI 3, only the descending aorta is involved. What is this type A stand for? Type A stand for involved, irrespective of the descending aorta involvement. Type A actually stand for indicates there is only, means if there is an ascending aorta involvement. Okay, if there is ascending aorta involvement. So you see in type A actually includes DVACI 1 and DVACI 2. Okay, that is the ascending aorta is involved in DVACI 1 and also here in DVACI 2 also. So this stand for type A includes both DVACI 1 and DVACI 2, and DVACI 3, that is a type B, involves only the descending aorta. So coming back to this question, in DVACI classification, dissection of the ascending and descending aorta is classified under type 1. Yes, you see therefore this picture, DVACI 1, you get both the ascending aorta as well as the descending aorta is involved. Yes, so the answer for this question is, in DVACI classification, dissection of ascending and descending aorta is classified under type 1. Yes. So let us move on our focus to now the vasculitis. Plethora of MCQs can be asked from the chapter vasculitis. Okay, though from UG you may not have given during your undergraduate secondary, you may not have given importance to this vasculitis, but in entrance exams, NEET exams, you will be getting more of this questions from the vasculitis. So now let us see the first question from the vasculitis. Biopsy finding in giant cell arteritis is all except, yes, is all except The primary finding is medial granulomatous inflammation. The intima is thickened and the lumen becomes reduced. Inflammatory lesions are not locally distributed. There is elastic lamina fragmentation. So here they have told about the biopsy findings. Okay, so in a giant cell arthritis, they have told the biopsy findings and they are asking which is not true. Okay, so before solving these questions, let us have an idea about the different types of vasculitis. So based upon the nature of the blood vessel involved, you have mainly three types of vasculitis. That is the large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Large vessel vasculitis or a granulomatous disease. Yes, granulomatous disease. Granulomas will be there in the large vessel vasculitis, and the examples are giant cell arthritis and Takayasu arthritis. Giant cell arthritis and Takayasu arthritis. And the medium vessel vasculitis. Medium vessel vasculitis, it is involves mainly the medium vessel, that is the arteries especially. Yes. So here you have mainly two important disease, polyarthritis nodosa and Kawasaki disease. Polyarthritis nodosa and Kawasaki disease. So polyarthritis nodosa, actually it is an immune complex mediated disease, and you will be having anti-endothelial antibodies, that is antibodies against the endothelium in the Kawasaki disease. Okay, this is about medium vessel vasculitis. Then the vasculitis, that is the inflammation of the vessels, which can affect the smaller blood vessels. Smaller blood vessels, what I mean here, arterioles, venules, and the capillaries. So there are vasculitis which affects predominantly these regions, okay, arterioles, capillaries, and venules. So the examples for these small vessel vasculitis includes microscopic polyangiitis, Beginner's granulomatosis, that is nowadays it is called as granulomatosis with polyangiitis. Beginner granulomatosis is the old name terminology, and the recent term is the granulomatosis with polyangiitis. That is, the granulomas will be there and involves the multiple vessels. Okay. Then Chokestraws syndrome, where you can have eosinophilia, asthma, and granulomas. And here in this vaginous, you will have granulomas, but without any asthmas. Here, all these conditions, there will be paucity of immune complex, often with ANCA, that is the anti-neutrophilic cytoplasmic antibodies. But the small vessel vasculitis can also be an immune complex mediated disease. Okay, like you have in SLE, okay, SLE associated vasculitis, IgA deposition. Okay, these are all the immune complex, that is the antigen antibody may be forming a complex, and these complex may be deposited in the blood vessels, resulting in the immunological damage to that blood vessel. So IgA, that is in Henash colon purpura, cryoglobulin in cryoglobulin vasculitis, and in Goodpasture syndrome. So this is about the overview about the classification of the vasculitis. Coming to our question, that is a giant cell arthritis, temporal arthritis. It is otherwise called as temporal arthritis because it commonly affects the temporal artery. So as it affects the temporal artery, it is mainly the headache, the patient. It usually, this giant cell arthritis affects the elderly males. This giant cell arthritis is common in the elderly males. Okay, so it is common in the elderly males, and usually the headache will be the most common manifestation, most common manifestation, and also it will be the headache will be the most common vasculitis related symptom. And jaw claudication will be the most specific symptom. Jaw claudication, that is when the pain is, the patient is, when he is masticating, there will be pain in the jaw muscles. Okay, that is a claudication pain. So if a patient is complaining of a jaw claudication pain, actually it is a very, very highly specific symptom for the giant cell arthritis. And sometimes these, when the involvement of the ophthalmic artery is there, the patient may go in for sudden blindness. Sudden blindness also can be there. So the associated other features includes arthritis, that is inflammation of the joint, polymyalgia rheumatica, okay, and also raised elevated ESR. So this will be the, now coming again back to the questions. Here, these are all the biopsy findings. So in the biopsy findings, you can see this image, and this is the blood vessel. Okay, this is the wall of the blood vessel, and what you can see is the granuloma. The arrows are pointing at the granulomas, and what the arrows is pointing also, it shows a giant cell. Okay, so I told you know that large vessel vasculitis usually has a granulomas. So granulomas, what you can see, you will be seeing an accumulation of the histiocytes, and also you will be seeing the giant cell. So granulomas will be always there in a giant cell arthritis. Okay, so this is a special stain. Okay, this is a special stain, and in this special stain, what you can see is you can see the highlighted one structure, okay, with the wriggles and all. So what is this? This is actually the internal elastic lamina. This is the internal elastic lamina, and what happens here in this internal elastic lamina? Is it continuous here? Yes, it is continuous here, but what happens here? It appears to be fragmented. Yes, the giant cell arthritis, you get fragmentation of the internal elastic lamina. So you have granulomas, you have this fragmentation of the internal elastic arteries. Actually, this is a clinical picture, that is where the patient is will be having the thickening of the temporal arteries. So, and what you can see is, coming back to the question, the primary finding is medial granulomatous inflammation. Yes, you have in the tunica media, you have this granulomatous inflammation. The intima is thickened and the lumen becomes reduced. The intima is thickened and the lumen becomes narrowed. See here, the intima is thickened, and so that the lumen is narrowed. You can see hardly any lumen here. Okay, so because of the lesion, the lumen is compressed. Okay, the lumen is compressed. And the third option and the fourth option, what you can see, that is a fragmentation. See here, there is elastic lamina fragmentation. Yes, there is elastic lamina fragmentation. Okay, the inflammatory lesions are not locally distributed. Okay, so are not locally distributed, but it is actually a locally distributed lesion. The lesions are seen only in the blood vessels. Okay, only in the blood vessels, and that too mainly in that intima, around that intima. The granulomas will be located more in the intima only. So this option is the wrong option. So inflammatory lesions are not locally distributed. Okay. Takayasu disease. The next question is the Takayasu disease most commonly affects celiac axis, coronaries, archa aorta, renal artery. So they are asking Takayasu disease affects which arteries commonly? Takayasu arthritis, the other name for this Takayasu arthritis is the pulseless disease and aortic arch syndrome. So the other name for Takayasu arthritis is the pulseless disease and aortic arch syndrome, and it has a strong predilection for the aortic arch. Okay, so the name itself is, it is aortic arch syndrome. Okay, so and it is a common in adolescent girls. It is common disease in adolescent girls, and you can see granulomatous vasculitis. I told you this large vessel vasculitis will have a granuloma as a feature. Okay, so this is a granulomatous vasculitis. And in Takayasu arthritis, subclavian artery is the most common vessel involved. So subclavian artery, okay, because it supplies the major source of supply for the upper limbs and the head and neck. So subclavian artery, the most common vessel involved. And coronary arteries is the least commonly affected artery. And what usually the patient presents with? The patient presents with a claudication pain. Yes, because the vessel is involved. And the vessel is involved means the blood flow also will be low. So the patient will be presenting with a claudication pain. And if you measure, BP will be lower and the pulse will be weaker in the upper limb than in the lower limb. Okay, because here the subclavian artery, which is the major source for the upper limb, is affected. Okay, so it is the artery will be much more narrowed down. So the patient will be having lower BP and weaker pulse in the upper limb when compared to the lower limb. So you can see, and also what is this picture? You can see this narrowing of the subclavian vessels, and you can see this in the cut section grossly. You can see that artery lumen is reduced. Okay, so you can see here the vessel lumina is narrowed down. And again, these are all the granulomas which you can see in the vessel wall, and you can see this, the arrows are pointing out at giant cells. So the answer for the question is Takayasu disease most commonly affects arch of aorta. So only it is called as aortic arch disease. Aortic arch disease. Now the next question. Which of the following disease is known as mucocutaneous lymph node syndrome? Mucocutaneous lymph node syndrome. That is, it affects the mucous region, membranes, mucous membranes, cutaneous skin, and also lymph node. Okay. So it is actually, before solving this, let us know about this Kawasaki disease. So Kawasaki disease is called as mucocutaneous lymph node syndrome. It is actually seen in children less than 5 years. Yes, vasculitis, if you see vasculitis in a child, think of Kawasaki. Already we have learned that in Kawasaki there is anti-endothelial antibodies. There is antibodies to the endothelium. Okay, so remember, anti-endothelial antibodies are seen in Kawasaki disease. So how the patient presents with? It is a mucocutaneous lymph node syndrome. No? So mucous membranes, cutaneous skin, and lymph nodes will be involved. So the patient will be having an erythematous mouth. Okay, the mouth will be a reddish and with a red cracked lips. Okay, patient will be having a red cracked lips and strawberry tongue. Okay, so because of the erythema and the reddishness, and with also with the cracking appearance, the typical appearance is described as a strawberry tongue. Okay, and coronary vasculitis, actually it involves this Kawasaki disease in a child. It involves that coronary artery. So coronary vasculitis is a common event. So coronary vasculitis is a common event, and aneurysm. And remember, the most common cause of death is the myocardial infarction. Yes, in pediatrics, it can be asked if a child presenting with the symptoms like that of a myocardial infarction, a child with a myocardial infarction, a child with a cardiovascular disease, a child with an aneurysm, coronary aneurysm, you always think of Kawasaki. Okay, so Kawasaki, you always think in a child with cardiovascular, especially that myocardial infarction and aneurysm. And that aneurysm rupture is the most common cause of death in Kawasaki disease. So coming back to the question, which of the following disease is known as mucocutaneous lymph node syndrome? It is Kawasaki disease. The next question, vasculitis in Chokestraws disease is due to autoreactive T cells, anti-endothelial cell antibodies, anti-neutrophil cytoplasmic antibodies, immune complex deposition. If you remember my flow chart, the first chart which I summarized about this vasculitis, you will answer this question. What is the pathogenesis of this in Chokestraws disease? Chokestraws disease or Chokestraws syndrome is nothing but it is a eosinophil-rich granulomatous necrotizing vasculitis. So you can see much more granulomas. So granulomas you can see even in Chokestraws syndrome, and it is rich in eosinophils. So remember, if in any vasculitis, that is involvement of the blood vessel, if you can see much amount of eosinophils, like numerous eosinophils in a vasculitis, always think of Chokestraws disease, and this will be resulting in a necrosis also. So the patient presents with asthma, allergic rhinitis, and eosinophilia. So the patient presents with asthma, allergic rhinitis, and eosinophilia. You can correlate. So because of the allergy, because of the asthma, because of these things, the eosinophils will be more. So eosinophilia. And very interesting to note that in Church-Strauss syndrome, the most common cause of mortality is cardiomyopathy. So you can get a histological image like this thing. Here, this is around the blood vessel, and what you can see this pinkish, okay, that is a bright eosinophilic orangish cells, okay. The cells with this orangish cytoplasm are nothing but the eosinophils with a binucleated spectacle shaped nucleus, okay. So whenever you see more number of eosinophils in your blood vessel, always think of Church-Strauss disease. And the question is asking about what is its association, whether it is autoreactive T cells or anti-endothelial cell antibodies or ANCA, that is anti-neutrophil cytoplasmic antibodies, or immune complex deposition. Anti-endothelial cell antibodies, already we have seen that it is seen in Kawasaki disease. But what is seen in Church-Strauss disease is the ANCA. ANCA. Let us see what is ANCA. So ANCA is nothing but it is anti-neutrophilic cytoplasmic antibodies. Okay, analyze the name, anti-neutrophilic cytoplasmic antibodies. That is, antibodies are directed against the primary granules of the neutrophil and lysosomes of monocytes. Where are these granules are located? Usually the granules are located in the neutrophils where? In the cytoplasm. So anti-neutrophilic cytoplasmic antibodies. That is the antibodies directed against the primary granules of neutrophils and lysosomes of the monocytes. You have two types of ANCA, that is C ANCA and P ANCA. So denoted in short as C ANCA and P ANCA. What does it stand for? C ANCA means cytoplasmic ANCA. P ANCA means perinuclear ANCA. Okay, so these are the antibodies. You know that ANCA means anti-neutrophilic cytoplasmic antibodies. They are nothing but they are the antibodies. So antibodies means it has to target an antigen, no? So what are the antigens which target by this C ANCA? It is nothing but the target antigen is the proteinase 3. Okay, remember this proteinase 3. Okay, so sometimes this ANCA is also called as proteinase 3 ANCA. Okay, and perinuclear ANCA, that is the P ANCA, the target antigen is the myeloperoxidase. The target antigen is the myeloperoxidase. So P ANCA is otherwise called as myeloperoxidase ANCA. So in the exams, they may ask you which ANCA is seen in which condition. So C ANCA, that is the cytoplasmic ANCA, is seen in granulomatosis with polyangiitis. What is it? The other name which I told? It is vaginous granulomatosis. So vaginous granulomatosis is called as this granulomatosis with polyangiitis. Granulomatosis with polyangiitis. And this P ANCA is seen in conditions like microscopic polyangiitis, Chokestraws syndrome, good pasture syndrome, and inflammatory bowel disease. Inflammatory bowel disease. So remember the conditions in which you will get C ANCA and P ANCA. This is how a picture of C ANCA and P ANCA. Usually these are the antibodies, no? So these antibodies, they will be we'll be examining under, we'll be depicting under, finding under the immunofluorescence microscope. In the immunofluorescence microscope, this is actually a neutrophil with the 3 lobed. Okay, can you appreciate the neutrophil's nucleus? So you can see where you are seeing the fluorescence. You are seeing the fluorescence only in the cytoplasm. So you are seeing the fluorescence, the cytoplasm, you are seeing that fluorescence only in the cytoplasm. So you can see this fluorescence is highlighted, okay, in the cytoplasm. So it is C ANCA. But where is the fluorescent light is highlighted here in P ANCA? It is mainly around the nucleus. See this, mainly around the nucleus. The cytoplasm is relatively like a lighter, and see here the highlighted area is around the nucleus. So perinuclear, okay, that is around the nucleus. So only it is called as P ANCA. Okay, so this is how the image of a C ANCA will look like. So you can see the highlighted immunofluorescence will be emitted in the cytoplasmic region, whereas you can see in the P ANCA, the cytoplasm region is not emitting, and you can see the emittance only around the nucleus, and hence the name P ANCA. Okay, and you know where you get a C ANCA, where you get a P ANCA. Okay. And sometimes you may get ANCA positivity, that is both in the cytoplasm and perinuclear. Yes, you can get that immunofluorescence light emissions both in cytoplasmic as well as in the perinuclear region. And such ANCA are called as atypical ANCA. Yes, they are not typical of anything. They are expressing that emitting is immunofluorescence is emitting both in the cytoplasm and the perinuclear region. So such atypical ANCA are seen in conditions like systemic lupus erythematosus, autoimmune hepatitis, PSC. Okay, PSC, what does it mean? Primary sclerosing cholangitis. Okay, primary sclerosing cholangitis. And PBC, primary biliary cirrhosis. Primary biliary cirrhosis. So in these conditions, in addition to that rheumatoid arthritis, so in all these conditions, you will be getting this atypical ANCA, that is both cytoplasmic and perinuclear staining will be there. Okay, now moving on to the next question. Moving on the same question, vasculitis in Chokestraws syndrome is due to anti-neutrophilic cytoplasmic antibodies. Yes, you know this, no? Anti-neutrophilic cytoplasmic antibodies. Which ANCA will be seen? You can see in this Chokestraws syndrome, you will be getting P ANCA. In Chokestraws syndrome, you will be getting this P ANCA. Now let us move on to the other question. What is Stewart-Traverse syndrome? Stewart-Traverse syndrome, we are dealing with CVS and blood vessels. So what is Stewart-Traverse syndrome? Something to do with blood vessels? Let us see. It is called as encephalotrigeminal angiomatosis. It is the appearance of lymphedema in the ipsilateral upper extremities after several years of mastectomy. Skin looks like burn or scald caused by a staphylococcal skin infection. None of the above. So let us explore what is that Stewart-Traverse syndrome. So usually before going on to the syndrome, let us see what is port vein. Port vein is nothing but, this is otherwise called as nevus flammeus. Nevus flammeus, okay, nevus flammeus, that is the birthmark. Okay, nevus flammeus is the birthmark, and it grows during that childhood. It grows during the childhood, and it do not fade with the time. Okay, it grows during the childhood and it do not fade with the time. These are all the port vein. So now let's see what is this encephalotrigeminal angiomatosis. That is, it is a syndrome which you are familiar with, that is the Sturge-Weber syndrome. So the other name for Sturge-Weber syndrome is the encephalotrigeminal angiomatosis. So encephalotrigeminal angiomatosis. So what are the components of this syndrome? Facial port wine nevi. Yes, the patient presents with this type of port wine stains. Okay, we know, no, these stains will not fade away. Okay, these are the birthmarks. Leptomeningeal angiomas, that is the blood vessel proliferation in the leptomeningeal region. Mental retardation, seizures, hemiplegia, glaucoma. So the patient presents with all these symptoms, that is the encephalotrigeminal angiomatosis. So the other name for this Stewart-Traverse syndrome is the encephalotrigeminal angiomatosis, and here nothing like lymphedema occurs after the mastectomy in the upper extremity, and the skin is not looking like a burn or scald caused by the staphylococcal skin infection. So the answer for Stewart-Traverse syndrome is encephalotrigeminal angiomatosis, which is otherwise called as this Sturge-Weber syndrome. Now let us move on to the other question. That is true about what is true about bacillary angiomatosis caused by Bartonella quintana. Histology shows capillary proliferation, usually involves skin, bone, and brain, and all of the above. So this is how this bacillary angiomatosis looks. Okay, so before solving that MCQ, we'll see what is bacillary angiomatosis. It is usually actually caused by a bacteria called as Bartonella henselae and Bartonella quintana. So this what happens, this bacteria starts proliferating, and it mainly affects targets the immunocompromised host in HIV patients like these things. So mainly in the immunocompromised host, it presents as a this swelling, vascular proliferation swelling, okay, like a proliferation of the blood vessels, especially in the skin, bone, and the brain region. And this is the bacteria, and usually this bacteria is highlighted by a special stain that is called as Warthin starry stain. Warthin starry stain. Warthin starry stain is actually a silver stain which highlights this bacteria, and also Warthin starry stain is also seen in, also highlights your Helicobacter pylori. Okay, so please remember Helicobacter pylori, which causes gastritis, will be the special stain for H. pylori is the Warthin starry stain. Now moving on to other question. True about bacillary angiomatosis is caused by Bartonella quintana, The histology shows capillary proliferation, usually involves the skin, bone, and brain. And you now know the answer. It is all of the above. Now let us see this question. Identify the lesion in an HIV positive patient and histopathological examination showing the proliferating spindle cells as below. So you can see in an HIV patient, you can see this proliferation of the lesions, and they are asking what is the lesion: Port-Weinstein, Kaposi sarcoma, dermatomyositis, and Castleman disease. And it is usually the Kaposi sarcoma. It is a Kaposi sarcoma. So the Kaposi sarcoma, moving on to what is Kaposi sarcoma, it is caused by human herpes virus 8, okay, HHV 8. So it is actually a vascular proliferation. It is a proliferation of the small blood vessels, okay, that with the spindle cells. That spindle cells are actually nothing but these are the deriving of the vascular origin. So a tumor of the blood vessel of the vascular origin in HIV patient is called as a Kaposi sarcoma, and it is caused by human herpes virus 8. Human herpes virus 8. And the most common site is the skin of the feet. Okay, the most common site of Kaposi sarcoma is the skin of the feet. And apart from the skin, where else you can see this Kaposi sarcoma? In the lymph nodes. So skin is the commonest site, and the extracutaneous site, commonest extracutaneous site for the Kaposi sarcoma is the lymph nodes. And the most common site in the GIT is the duodenum. The most common site in the GIT is the duodenum. And it is usually initially will not be forming as a mass like this thing. It will be evolving in stages. The Kaposi sarcoma will be evolving in stages, that is in patch, plaque, and nodules. It can form as a patch, it can form as a plaque, or it can form as a nodule. So the answer for this question is the Kaposi sarcoma. Okay. So now let us see the most important questions. Okay. That is which can be asked is, see this question. A 45-year-old male was admitted with a diagnosis of acute myocardial infarction. 4 days later, he died, and autopsy showed transmural coagulative necrosis. Which of the following microscopic features will be seen on further examination? Fibroblast and collagen, granulation tissue, neutrophilic infiltration surrounding coagulative necrosis, granulomatous inflammation. So they are giving 4 options. Let us see this question. Earliest histological change in MI: macrophage infiltration, neutrophilic infiltration, waviness of the fibers, and coagulative necrosis. One more question actually I'm putting forward, because moving into the topic, before moving into the topic of myocardial infarction, that is the matching the morphological changes in myocardial infarction and the days of formation. That is, they are given. Nowadays the questions are asked like these type of, so it will be not be a straightforward MCQ with 4 options. You may have to match the findings. So these type of extended MCQs means you have this matching things. Okay, so 1 to 4 hours, 1 to 3 days, 7 to 10 days, 2 to 8 weeks, and they have given the options as well-developed phagocytosis of dead cells with the granulation tissue at margin, sarcolemmal disruption, increased collagen deposition with decreased cellularity, coagulation necrosis with loss of nuclei and striation with brisk interstitial infiltrate if neutrophils. So before solving these questions, let us understand like what happens in what are the gross and microscopical changes which occurs in the myocardial infarction. Okay, if you know this, then you can solve all these MCQs. Okay, so knowing the gross changes and knowing about the microscopical changes is absolutely essential to solve the MCQs. Okay, usually you will be getting about the one MCQ regarding this morphological changes in the myocardial infarction, which is the expected question. So the first, what happens now? In the gross changes in the initially infarcted heart, after 12 hours, it will not show any changes. Okay, so it will be none changes or occasional mottling will be there. But in the next 12 to 24 hours, you will be getting a dark color mottling, hemorrhagic mottling. And later what happens in 3 to 7 days, you will be getting a central yellow tan, okay, or yellow tan like appearance with hyperemic borders, And the scar tissue is formed at the 2 to 8 weeks. This is about the gross changes. Scar tissue is formed at the 2 to 8 weeks. That is the gross changes. Now, let us see this picture from Robbins. Actually, this is this is a picture taken from Robbins, and this is a gross picture, gross picture of your infarcted heart, which is stained with a stain called as TTC. TTC stands for triphenyl tetrazolium chloride. Triphenyl tetrazolium chloride. And what happens? This enzyme, this stain stains the LDH, that is a lactate dehydrogenase enzyme in the myocardium. Normal heart tissue will be having that LDH. Yes, normal heart tissue will be having that LDH, and because this normal myocardium is having that LDH, that TTC will stain that normal myocardium as mahogany brown in color. See this is that mahogany brown color, and the normal viable myocardium has LDH in it. So the TTC stains for that. Okay. But if there is an infarction, you know, it is a death of a tissue. If there is a death of a tissue, you will not get enzymes in the tissue. No, instead, those enzymes only will be coming as a cardiac markers. So you will not get enzymes inside the cardiac tissue, inside the cardiac muscle. So that stain will not act upon those cells, those area. And if the stain is not taking part, they're not taking a part of the tissue in a myocardium, you say that that area is infarcted. A viable tissue will be showing a mahogany brown color, and an infarcted tissue will not take up the stain, whereas a site of previous scar, a previous MI would have resulted in a scar tissue. No, that scar will be showing a gray-white appearance. That scar will be giving you a gray-white appearance. This is the triphenyl tetrazolium chloride. Now let us see the microscopic morphological changes which occurs in the myocardial infarction. This is a table column given in the Robbins. Actually, it is like you have to memorize more things, but actually I try to make it much more simpler. So we'll categorize the morphological changes into the things which happens within 24 hours, within 1 to 3 days, what happens, 4 to 7 days, 7 to 14 days, and 2 to 8 weeks. I repeat once again. So you can categorize the morphological changes which occurs in the MI as what happens within 24 hours, within 1 to 3 days, or 4 to 7 days, or 7 to 14 days, 8 to 14 days, and 2 to 8 weeks. So now let us see what happens in the first 24 hours. So first 24 hours, what are the microscopic changes which can occur in the myocardium? Okay, so the first thing you see is that you can get this is a normal cardiac muscle, and you can get striations. Normal cardiac muscle will be having a striations, and you will be having a centrally placed nucleus. Okay, this will be a syncytial tissue. No, so you will be getting that nucleus, multinucleated, and the striations will be there. But when there is a myocardial infarction, what happens? The striations are lost. And you can get a contraction band. Okay, you can get a contraction band, and the earliest change is that waviness of the fibers. That is what happens. These muscle fibers will be going in for the waviness appearance. That will be, they are not a no more. They are not a normal muscle fibers. So they are like a wavy muscle fibers. So they are having a waviness of the muscle fibers. So what happens here? There is a waviness of the muscle fibers will be there. Contraction band necrosis will be there. The striations are lost. And you can see these are all the necrosed myocardial fibers. And you can see here, these are all the hypereosinophilic. Okay, compared to this area, these muscle bands are appearing much more darker stained, much more hypereosinophilic. And what you can see here, you are not seeing here, you are seeing a normal nucleus, but you are seeing here is the fragmented nucleus, but you are seeing a fragmented nucleus. Okay, so these are all the changes which can occur in the less than 24 hours. That is a coagulation necrosis, you can remember. What happens in the 1 to 3 days? 1 to 3 days, what happens? These are all the dead fibers. So anything which is dead in the body or which is unwanted in the body, usually the scavenger cells, that is the neutrophils, acute thing, acute injury is happening. So the neutrophil comes to the point of injury and the neutrophil will try to engulf, will try to eat away all these dead fibers. The neutrophil try to eat away all the dead fibers. Okay. So what happens in the 1 to 3 days? It is predominantly the brisk neutrophilic infiltrate. Okay. So next is these neutrophils may stay even for the 3 to 4 days also. It can be very brisk predominant. So next 4 to 7 days you will be getting macrophages. You will be seeing the neutrophils also, but in addition you will be getting the macrophages, which is also clearing that unwanted tissue. Okay, first neutrophils followed by macrophages. Next thing what I told you to remember, that is the 7 to 14 days. So in the 7 to 14 days, what happens? The neutrophils are moving away from the skin, and now it is predominantly the macrophages. These are all the large cells, that macrophages. And the most important point is the granulation tissue. Yes, granulation tissue. You must have read it in the wound healing chapter. That is, the granulation tissue is nothing but it is a tissue formed wherever there is an injury. It is trying to like a cement or like a joining glue. Okay, between the two disrupted structure. Okay, that wounded structure it tries to heal by itself. The same scenario happens in the myocardial infarction. It is an infarcted tissue. So the tissue tries to heal by itself by forming a granulation tissue. So the granulation tissue, what is its composition means? You can see this capillaries, neocapillaries, that is a new capillary formation. That is neovascularization or angiogenesis takes place. And you can also see that proliferating fibroblast. Proliferating fibroblast. It is these fibroblast only produces the collagen. You know, no? Like in a healed myocardial infarction, there will be a scar tissue will be there. What is it actually scar tissue? Scar tissue is nothing but it is the fibroblast which has produced that collagen. So those thing is the actual scar tissue. So you will be getting in a granulation tissue in the 8 to 14 days, and the granulation tissue is composed of these proliferating capillaries, fibroblasts producing collagen, and these macrophages. So in the 2 to 8 weeks, it is the collagen which is fully laid down. It is the collagen which is fully laid down, and you get the completely formed scar tissue, which is composed of this collagen, that is a scar tissue and fibroblast. Now let us coming back to our question. A 45-year-old male, yes, admitted with diagnosis of acute myocardial infarction. So 4 days later, so the duration they are giving is 4 days later, he died, and autopsy showed transmural coagulative necrosis. Transmural, that is the entire thickness. Okay, transmural, always remember entire thickness is showing that coagulative necrosis. Which of the following microscopic features will be seen on further examination? Fibroblast and collagen. When you will see fibroblast and collagen? Fibroblast and collagen actually will be seen initially in the granulation tissue in the 7 to 14 days, but actually the scar tissue, well-formed scar tissue, that is in the 2 to 8 weeks only, you will be seeing that fibroblast and collagen. Granulation tissue, no, I told granulation tissue is from the 8 to 14 days. Then granulomatous inflammation. Why the granuloma should come here in myocardial infarction? So ruling out the other options, it is the neutrophilic infiltration surrounding the coagulative necrosis. Then this thing, earliest histological change in myocardial infarction. Macrophage infiltration, neutrophilic infiltration, waviness of the fibers, and coagulative necrosis. Macrophage and all will be starting coming only at around the after fourth day. Around fourth day. Neutrophils, mainly the brisk neutrophilic change will be there in the 1 to 3 days, but it is not the earliest change. Coagulative necrosis also will be the waviness of this fiber. So the most opt answer here will be the waviness of the fibers. Now coming to the other question, that is matching the morphological changes in myocardial infarction and the days of formation. What happens in the 1 to 4 days? What happens in the 1 to 3 days? What happens in the 7 to 10 days? And in the 2 to 8 weeks? And the options are well-formed phagocytosis of dead cells with a granulation tissue at margin. Which time the granulation tissue is formed? You know it is 7 to 10 days. Yes. And sarcolemmal disruption, increased collagen deposition with decreased cellularity. Increased collagen deposition with decreased cellularity. You know that is a scar tissue. Scar tissue, when I told, it is 2 to 8 weeks. Okay. Now moving with these two options, that is a sarcolemmal disruption and coagulation necrosis. Coagulation necrosis with loss of nuclei and striation with brisk interstitial infiltrate of neutrophils. So neutrophils, I told it is 1 to 3 days. Coagulative necrosis also around these 1 to 3 days. But the earliest change, that is at electron microscopically, you can appreciate the sarcolemmal disruption in 1 to 4 days. So the option will be B, that is one is B, that is in the first 1 to 4 hours, you will be getting a sarcolemmal disruption. And in the 1 to 3 days, you will be having a coagulation necrosis with the loss of nuclei and striation with brisk interstitial infiltrate of neutrophils. Third is A, that is in the 7 to 10 days you will be getting a well-developed phagocytosis of dead cells with the granulation tissue at the margin. And the fourth will be the C, that is in 2 to 8 weeks you get a scar tissue. You know the scar tissue is increased collagen deposition with decreased cellularity. Now moving on to the other question, that is match the cardiac markers with the time of appearance in the myocardial infarction. Yes, it is like a similar type of extended MCQ, that is the matching type of MCQ. That is what they have given is, they have given 4 markers and they have given you the 4 different times and they are asking you to match at which time you will be getting elevated or which will be you will be getting ideal time for measuring these markers. And the options they are given is 48 to 72 hours, 7 to 10 days, 2 weeks and 4 to 5 days, and they are asking us to mark the option. For solving this MCQ, this table column will be helpful for you. Actually, here I have tried to summarize the different serum cardiac markers and when they are starting to appear first in the serum and when they are reaching the peak and at what time it normalizes. First, let us see the creatine phosphokinase. Creatine phosphokinase begins to elevate in the 2 to 4 hours and it peaks at 24 hours and it normalizes at 48 to 72 hours. Yes, lactate dehydrogenase. It begins at 24 hours, peaks at 4 to 5 days and normalizes at after 10 days. AST or SGOT, these are all like non-specific, can be elevated in liver enzymes also, but it is better to know for our exam point of view. They begins to elevate within 12 hours and peaks at 48 hours and normalizes at 4 to 5 days. Troponin I or troponin T, that is it begins at within 22 to 4 hours. Yes, you know that is specific cardiac marker. Okay, the marker of choice is a troponin I or troponin T. It begins at to elevate at 2 to 4 hours itself. Peaks at 48 hours. Yes, but normalizes after 7 to 10 days. Okay, it stays for much more longer duration. Okay, you can, but so because of these features only, it is called as an ideal cardiac marker. Myoglobin, it is highly non-specific marker. So it is a highly non-specific marker. Okay, even a person with a road traffic accident or muscle injury may show elevation of this myoglobin. Okay, even your creatine phosphokinase is also a non-specific marker. Okay, except that CKMB may be present in the myocardium. This myoglobin is the first marker to get elevated. But why we cannot use this marker is it is highly non-specific, and also it normalizes at 24 hours. Now let us, with this knowledge, let us try to solve this question. Match the cardiac markers with the time of appearance in myocardial infarction. They have asked CKMB, troponin T, LDH, and SGOT. So the option here is the option A. That is, one is A, and it is actually matching with these things. CKMB will be elevated in 24 hours, troponin T 48 hours, and that is the peak value. Here they are meaning about the peak values, and LDH 4 to 5 days, and SGOT it is 48 hours. Okay. Shall we end with this? Any doubt in the chapters? Shall we end the session?
No, I still don't get it.
Okay. Shall I end or shall I continue up to 10 o'clock?
Yes, please continue.
Okay. So we'll solve one more MCQ. A 10-year-old boy died of acute rheumatic fever. All the following can be expected at autopsy except Ashcroft nodules, rupture of chorda tendineae, metallum patch, fibrinous pericarditis. The other question, Ashcroft bodies in rheumatic heart disease will show all of the following features except Ashcroft cells, epithelioid cells, giant cells, fibrinoid necrosis. So all of you will be knowing that we are dealing with the rheumatic heart disease. And what happens in rheumatic heart disease? It is the pathogenesis is actually a molecular mimicry. Molecular mimicry is nothing but it is a pathogenesis of an autoimmune disorder. That is, what happens, the antibodies produced against a bacteria, say for here the example, group A beta hemolytic streptococcus, that is the antibodies produced against those bacteria will be cross-reacting with the antigens in the myocardium, joint, brain, skin, subcutaneous tissue. It is because of these regions. These regions will share the antigens. Like these regions will share the antigens like that of a streptococcus. So the antibodies are cross-reacting with these antigens. So this is the actual thing happening. And in the rheumatic heart disease, you will be getting a peculiar structure called as the Ashcroft body. So Ashcroft body. So Ashcroft body is nothing but usually you will be seeing in a myocardium, you will be getting.
Hey, can you let my friend in?
Pardon?
Can you let my friend in?
Ashcroft body you will be seeing in the myocardium. So Ashcroft body is nothing but it is a collection of the aggregates of the histiocytes. So what happens in the myocardium because of the immunological damage? There occurs the collection of the histiocytes. There you can get a collection of the histiocytes. Yes. There occurs collection of the histiocytes. So if this is a collection of the histiocytes, actually here in this Ashcroft body, you will be getting a aggregates of the histiocytes. Also, you will be getting a fibrinoid necrosis. So you will be getting a fibrinoid necrosis. So this collection of these histiocytes along with the collection of this fibrinoid necrosis, the entire structure is called as the Ashcroft body. So Ashcroft body can be seen in pancarditis. Pancarditis, that is, a pancarditis means involvement of all the layers of the heart. That is in the myocardium, endocardium, pericardium. So in Ashcroft body can be demonstrated in all the three layers. And also it is seen in the acute rheumatic carditis. It is especially in the acute event. Okay, especially in the acute stage, you can get Ashcroft body. So in this rheumatic heart disease, you will be that histiocytes. I told, no, there will be an aggregates of the histiocytes. So these aggregates of the histiocyte, these histiocytes alone is called as the Anishkov cells. So Anishkov cells are nothing but these are all the
Will you shut up?
These Anishkov cells or the histiocytes, which you can see in a rheumatic heart disease. Anishkov cell is the histiocyte which you can see in the rheumatic
Will you shut the fuck up, bitch?
heart disease. And what is so peculiar about this Anishkov cell is
Shut the fuck up.
Anishkov cell is nothing but it is a cell. See, I request to keep silent in the meeting. Anishkov cells, usually you will be getting the cells in the longitudinal section. You will be getting the chromatin in the form of a caterpillar. Okay, chromatin you will be getting in the form of a caterpillar. This caterpillar like chromatin is usually specific for this Anishkov cells. In a longitudinal section, you will be getting that caterpillar like chromatin, and you will be getting a caterpillar like chromatin, and these Anishkov cells in the cross section, it will be getting you like an owl's eye like appearance. So Anishkov cells, you will be like getting a caterpillar like chromatin in the longitudinal section, and in the owl's eye like appearance in the cross section, and the entire thing is called as the Ashkoff body. So Ashkoff body is nothing but it is a collection of the aggregation of the histiocytes, and also you will be getting that these histiocytes are called as Anishkov cells, which on longitudinal section it is called as the with the caterpillar chromatin, and in the cross section you have like an owl's eye like appearance. And the Ashkoff body is the collection of this thing, and Ashkoff cells is nothing but the giant cell. And in rheumatic heart disease, you will be getting the vegetations, and these vegetations will be along the line of the closure, And in the pericardium, you will be having the bread and butter appearance. So the bread and butter appearance in the rheumatic heart disease, in the pericardium of the rheumatic heart, bread and butter pericarditis, you will be getting that in apart from rheumatic heart disease, you will be getting in Dressler syndrome. Dressler syndrome is nothing but it is a post myocardial infarction syndrome. It is a post myocardial infarction syndrome, that is after the myocardial infarction, the patient may be after some few days, 1 week, the patient may be complaining of the chest pain. So it is because of the initiation of the treatment. So that is called as a Dressler syndrome. In SLE, uremia, trauma. So in all these conditions, you will be getting bread and butter pericarditis. So bread and butter pericarditis is actually nothing but it is because of the deposition of fibrin-like material in between the both the layers of the pericardium. So it is like a fibrinous material. So it is like a fibrinous material which is deposited between the two layers of the pericardium. So when you try to separate it, you will be getting this fibrinous deposit that is called as bread and butter. So similar type of bread and butter pericarditis you can see in rheumatic fever, Dressler syndrome, SLE, uremia, and trauma. And also, these are the changes which you can see in an acute rheumatic carditis. But in chronic rheumatic carditis, what you can see is that you can get the fibrosis of the walls. Okay, you know the walls are getting fibrosed in the rheumatic carditis. So you get a fibrosis of the wall, and you can get a typical appearance called as the fish mouth appearance or buttonhole stenosis. Fish mouth appearance. So fish mouth appearance of the cardiac walls and the buttonholes like stenosis is seen in that chronic phase of the rheumatic carditis. And what are all the valves involved in the rheumatic carditis? It is mitral valve is involved most commonly. Mitral valve is involved most commonly, and rheumatic heart disease is the most common cause of mitral stenosis. Rheumatic heart disease is the most common cause of mitral stenosis. And rheumatic, this after the involvement of the mitral valve, aortic valve is the second commonest valve to be involved, followed by tricuspid and pulmonary. So the order of involvement of the valve will be mitral, followed by aortic, and followed by tricuspid and pulmonary. So, and also you can get a lesion called as McCallum plaques. McCallum plaques are nothing but these are all the plaques. These are like an yellowish lesion which can usually seen in the posterior wall of the left atrium. Posterior wall of the left atrium, because of the jet of the flow of the direction of the flow, you can get a yellowish plaque in the posterior wall of the left atrium. That is the McCallum plaques. So coming back to this question, a 10-year-old boy died of acute traumatic fever. All of the following can be expected at autopsy except Ashkoff nodules, rupture of chorda tendineae, McCallum patch, fibrinous pericarditis. You know Ashkoff nodules will be there, McCallum patch will be there, and fibrinous pericarditis. What is the name? Bread and butter pericarditis. And what you will not see is the rupture of chorda tendineae. Usually in myocardial infarction only, you will be getting that rupture of chorda tendineae, not in rheumatic fever. And the other question is the Ashkoff bodies in rheumatic heart disease will show all of the following features except, that is, Ashkoff cells, epithelioid cells, giant cells, fibrinoid necrosis. Yes, you will be seeing the Ashkoff cells. Yes, you will be seeing the fibrinoid necrosis. And coming to these two options, epithelioid cells and giant cells, you will not see epithelioid cells. Epithelioid cells, where you will see epithelioid histiocytes, usually you will see in the granulomatous inflammation. Okay, in tuberculosis, you will be seeing that epithelioid histiocytes, and that you will not see in rheumatic heart disease. And giant cells, usually you will be seeing in rheumatic heart disease. Okay, so with this, I end this session. I kindly request you to give the feedback of the session. If you're having any doubt also, you can put it in the chat box. Kindly put your feedback about this session in the chat box. So tomorrow we'll be seeing with the MCQs from the respiratory system, and we'll be moving on similar with the directions, similar with other systems also.
Yeah, Vimal. Hello.